Okay, I think we'll go ahead and get started. Welcome, everybody. I know some more folks may be joining as we get going, but we're extremely excited to have our first IHPI 20 Fall Seminar Series presenter today. We're doing it virtually, and we're thrilled that so many of you are joining us in this new method of IHPI Seminar Series, as well as I'm sure many other seminars that you're participating in. But we're just thrilled to have Dr. Chad Ellimoottil kicking us off this year. Chad is an assistant professor of urology, and he is the director of the IHPI Telehealth Research Initiative Incubator, and that's what we'll be hearing about today. Chad has a lot more accomplishments, but I'm going to keep this introduction brief so that we can get to this exciting presentation. For those who don't know me, I'm Sarah Hawley. I'm the IHPI faculty lead for education and training. So I will be moderating. What that means is not too much. I'm going to be just kind of following the chat, letting Chad give his presentation. We'll have time for questions at the end. If you have a question as he's speaking, feel free to put it in the chat, and I'll be kind of following that. And at the end, hopefully asking you to unmute and ask your question, and hopefully getting to most of the questions. If we don't get to them all, we can share them with Chad and follow up kind of offline. Please know that Kara Gavin is live tweeting this presentation, hashtag IHPI20. So please do so as well. I know there'll be a lot of great information we want to get out there. And without further ado, I will turn it over to Dr. Ellimoottil. Thank you so much, Chad.
Yeah, thank you. Thank you, Sarah, for that introduction. And thank you for having me. I'm super excited to be here to present on telehealth, which has largely, a lot of the research has actually largely been supported by IHPI and initially through Improve. And so really excited to kind of present what we've been doing for the last couple of years. And so the title of the talk is Telling the Story of Telehealth at IHPI. And so I think you'll kind of understand the meaning of that title as the presentation progresses. And so just briefly about me, only so that you can sort of understand my lens that I view telehealth through. And there's kind of three different perspectives. The first is clinical. So I've been a big advocate for telehealth for a very long time, and been performed video visits since about 2016 with my own patients. And then on the operations side, I work with the health system, but then within my department as the medical director of telehealth for the Department of Urology, and has been part of that leadership as we've gone through these unprecedented transformations. And then most relevant here, and the focus of this talk is the work through IHPI as the director of the Telehealth Research Incubator. And so the Telehealth Research Incubator is essentially a collaborative. It's a group of people that are interested in telehealth research. And there's folks that have been doing telehealth research for 10 years and people that are just interested in it now. But primarily what we do is try to advance research through the lens of the health services researcher. So rather than working with development of software and clinical trials, it's more about trying to understand the population level impact of telehealth, specifically on healthcare costs, quality, access, and patient experience. And I've always felt that this work was important. I've always felt that this was kind of lagging in the literature. But I think now that there's been massive growth in telehealth and it's really become a part of our healthcare delivery system, it's all the more important to have all the smart people at IHPI involved studying all the different aspects of telehealth delivery. And so, for a long time, there's been a lot of people that are interested in telehealth, and I think that people, the researchers that we've worked with, have a lot of strong evidence. They've been studying it for a long time, and studying it on your own is good, and I think that does kind of help promote the message of telehealth and find the advantages of it. But really, the mission of the Telehealth Research Incubator was to actually use collective voices. So to be able to kind of tell the story of telehealth, because a single researcher can only do so much. So if we have a lot of researchers that are kind of in similar areas, bringing that together, disseminating that information together to really be able to tell that story. And so that's always really been the fundamental mission of the Telehealth Research Incubator, using our collective health services research lens to inform telehealth policymaking. And the formula for that is pretty simple. Number one is to kind of guide investigators on what is policy relevant topics related to telehealth. And Eileen and Sarah from the IHPI policy engagement team are really on the pulse of policy and have been able to kind of send over intel for us to kind of figure out what are the most important things out there. Number two is to make it easier to do telehealth research. And so, there's a lot of, there's a strong need to sort of avoid reinventing the wheel in terms of definitions and the way that surveys are structured, or the way that secondary data analysis is done. So making it easier to do telehealth research has been a big function of the incubator too. And then finally, to integrate, cross-pollinate, and then amplify the work of our IHPI colleagues so that we could kind of tell a coherent story to policymakers and everyone else that's willing to listen. And so who's telling the story of telehealth at IHPI? So fundamentally, there's a core team. So Emma Steppe, who's been working with, she's an IHPI project manager, has been working very closely with the Telehealth Research Incubator for several years, has really been kind of the foundation here. So Sophia Eng, who's one of the biostatisticians that works with us, and Z-Way as well. And then at various capacities, there's been dozens of people over the last couple of years that have worked with the Telehealth Research Incubator, or just worked on their own, and we know about their work, so we're able to disseminate it together. So I think that this is really a story about IHPI members and the work that's being done at IHPI. And so throughout this presentation, that's my goal here, is that I'm essentially going to kind of highlight the work that's being done around some very important policy topics. And so this is the chapters of the story. The first is that I'll kind of lay the landscape out and talk about telehealth policy and trends. What's been going on in the last couple months, and what do we think is going to happen in the future? Number two, 3, and 4 of this presentation, I'll talk about what I think are kind of the biggest policy areas right now in telehealth, the biggest unknowns and gaps that need to be filled. And then I'll talk about how IHPI researchers are filling those gaps. So we'll start talking about the impact on disparities. Is telehealth going to improve disparities or worsen disparities? A big argument that it could improve disparities, especially in rural health and other areas, but you have to have access to the technology to do that. So we'll talk about that. We'll have a discussion about healthcare spending. So one of the reasons that telehealth has really not taken off for the last 20 years since it was first initiated by the Medicare program is because the Congressional Budget Office has always scored it poorly and said that it's going to increase healthcare spending. Is that what's going to happen, or do we not know? And so I'll kind of talk about what the impact is that we think on healthcare spending and what IHPI members have been doing in that space. And then I'll finally talk about the impact of telehealth and clinical outcomes, which is really the most important part. How does it impact the individual patient? And more importantly, how will it impact on a population level, all these individual patients? So starting with telehealth policy, and just for a little level setting, what is telehealth and what am I talking about here? So telehealth is specifically the use of remote technology to diagnose, to treat, and to manage health. So the traditional form of healthcare that I'll refer to is going to see a healthcare provider inside a clinic, having that interaction, and that's the only exchange of medical information that's being done. Telehealth is using any sort of technology to actually as a substitute for that interaction. So commonly we think about video visits and video consultations, but there's also using emails, patient portals, using sensors, and a lot of people that are on this webinar and people that have been working doing IHPI research for a long time have been working in sensors and wearables and all those types of technologies, and so those are all part of telehealth. And so for all intents and purposes, virtual care, telehealth, telemedicine, and digital health is nowadays used interchangeably, and I'll use them interchangeably during this talk as well. So let's talk about the telehealth policy landscape. So telehealth has been around for a very long time. So telehealth, I'm not going to go into the historical origins of telehealth, but from a policy standpoint, it's been around at least for decades. In fact, the Medicare program started paying for it in 2001. And so the intent of telehealth was to improve rural care. And that's why it was primarily limited there and regulated like that. So in order for a provider to be reimbursed for a telehealth visit that they do with the patient, that patient actually had to not only be in a rural area, but they weren't able to connect from home either. So that means that they had to go to a medical facility in order to connect. That's a really important policy point. That's called the originating site requirement. And many people believe, even CMS themselves in their report to Congress, that that's been the single reason why telehealth has never taken off for the last 20 years until recently. And people know this, insurance companies know this, the Medicare program knows this, and that's been a switch that's been turned off for a very long time, only because they wanted to restrict the growth of telehealth. And so, it was like that for a very long time. Not to say that between 2001 and 2020, there weren't any milestones. Along the way, there's been mild milestones. In 2016, big for the state of Michigan, commercial payers like Blue Cross Blue Shield of Michigan actually started to removed that originating site and started to cover visits from home. So that was a big thing. That is actually how Michigan Medicine initially got interested in telehealth and started to build that into their broader strategy. The Medicaid program in 2019, early 2020, removed that restriction, allowed patients to connect from home, and joined about 20 other states that were doing the same. The Medicare program did start to make some small movements in that direction. So they started to cover telestroke and for end-stage renal disease, and then also put in waivers for alternative payment models like accountable care organizations and bundled payments and so forth. So there was a little bit of demonstration, a little bit of interest in this area, but it was definitely kept restricted in the Medicare program. And then finally, probably one of the biggest things that probably didn't get a lot of attention because of the virus was that at the beginning of 2020, the Medicare Advantage plan actually allowed patients to connect from home. So there was some movement over the last couple of years in the direction of allowing patients to connect from home, but nothing could compare to what happened in March 2020. And so in March 2020, there was just this perfect storm of a strong desire for social distancing from healthcare providers who wanted to protect their staff and themselves from being exposed to the virus, and then patients who were scared to come into clinic and who wanted to maintain safe social distancing, stay-at-home orders. All of that combined with a lot of aggressive policymaking, or I should say deregulation. And so the deregulation that we've been waiting for for the past 20 years for Medicare actually happened in March 2020. They allowed patients to connect from home, allowed practice across state lines, patients can have co-pays waived, and all of this was done in the spirit of the virus, in the spirit of the public health emergency, to help keep patients safe and to keep healthcare providers safe. And because of that, that's why we saw huge growth in the use of telehealth. And so the question is, what's going to happen afterwards? What's going to happen after the public health emergency? When's the public health emergency going to be over? And so one thing I know for sure is that telehealth, from a policy standpoint, will stay. This is Seema Verma from the Medicare program. The head of the Medicare program has said repeatedly, this is a quote from her: with these transformative changes unleashed over the last couple months, it's hard to imagine merely reverting to the way things are before. And so the policy conversations are not about whether Medicare should continue to cover telehealth. It's really about how they should cover telehealth. Should they pay the same amount? Should they restrict it to certain conditions? Should they restrict it in alternative payment models? These are the conversations that are happening, not so much should it go away, it's a bad thing. So this is definitely going to be a big part of our healthcare delivery moving forward. Most people are on board with this, bipartisan support. Most organizations are on board with this too. There's a letter that 340 organizations, maybe many of your professional societies were part of this letter, that so there's that originating site that I mentioned earlier actually takes an act of Congress to change. It's not regulatory, so CMS can't make that change. So there's multiple bills out there. This bill, House Bill 7663, has gotten quite a bit of momentum to remove that site, that exclusion of the originating site permanently. It has I think it has 20 to 30 co-sponsors right now, bipartisan support. So it's likely something is going to pass. It's not exactly sure what, but something will pass to make this more permanent for Medicare. Medicaid, Blue Cross Blue Care Network in the state of Michigan, they're going to continue coverage. They were actually doing it before the pandemic was over. Our state in general has actually, before the pandemic started, our state in general has been very favorable. Our governor recently signed some executive orders to expand telehealth coverage too. So it's not so much about whether it's going to go away. It's really about how how it's going to exist from a policy standpoint. So let's talk a little bit about telehealth trends. So what's happened in the last couple months? And so many of you who work on the clinical side are probably familiar with what happened at Michigan Medicine over the last few months. This happened nationally. Every curve I look at looks identical. And this really happened across the country in terms of what happened to outpatient care in the months of March and April. Most systems, most practices shut down in-person care. So there was a big drop. This data is from Epic. And it is, there's 3 lines that you can pay attention to here. The purple line represents total care. The blue line represents office care, so coming into the office. And then the green line represents telehealth visits. And just the data here, just like the data at Michigan Medicine and most health systems, you see a 60 to 70% drop in outpatient care between March and April because of the pandemic. And some of that, not all of it, just some of it was salvaged through telehealth care. Most people were actually deferring care as opposed to being seen through a virtual visit, even if they were given that option. And so in April and May, what you see is that there's a steady growth of telehealth and a steady plateau of in-person care during these months. But this is also a time when health systems were starting to understand that they need to bring patients in because their volumes are so low. And so they started to implement safety measures, making it safe to come back, do marketing around that. And so what you see is that there was a growth again in total care. At Michigan Medicine, we're about pre-COVID levels now. And but most of it, almost 100% of that rebound that you see in this Epic data, but also at Michigan Medicine is due to in-person care. And virtual care does seem to drop off a little bit. And in this data, it's at about 20%. At Michigan Medicine, we're about 16 to 20% virtual right now. And so this is some data that was put together by Sophia Eng, one of the biostatisticians who looked at Blue Cross Blue Shield data. So all privately insured Blue Cross patients in the state of Michigan. And what we see again is a very, very similar trend. Yellow represents the total care, red represents in-person care, and yellow and blue represents virtual care. And you see the same trend here where there's a peak in virtual care and then it starts to come down. Grace, one of the clinical fellows, clinical scholar fellows, is doing a study looking at telehealth by specialty, specifically looking at surgical specialty and what happened during this time period. And so these months are, the months down there is essentially kind of the same time period where you see a peak. What's interesting in her study is to try to understand how does it differ by specialty, by surgical specialty specifically. And you can see that each one of these lines represents a different surgical specialty. And a lot of people had a different narrative as to what about their virtual care use. There was most of the surgical specialties that were heavily E&M focused, like urology and OB-GYN had big spikes in use. And then, but all surgical specialties did start to decline as in-person care started to ramp up. And that's certainly true for our department, certainly true what we see at Michigan Medicine. This particular study, when we're studying surgery, it's important to kind of understand that a lot of them are post-operative visits that may not be billed. So Grace, for her studies, focused specifically on new patient evaluations to kind of understand the trend in usage for surgical fields. So what's going to happen? What's going to happen in the future? And this is a slide that I tend to kind of, or this concept or conceptual model that I like to bring up when we talk about telehealth. And so it's a Gartner hype cycle. You may have heard of this before. And it really has to do with the evolution of technology, and it can apply to all different types of technology, but it certainly applies to virtual care. And this is the hype cycle. So the way that the cycle goes is that you start with some sort of innovation, and you get to this peak of inflated expectations, like the technology, it's going to save the world, virtual care is the best thing possible. Then you go into this trough of disillusionment when reality starts to really hit the road. And then eventually you come out with the slope of enlightenment. And so with virtual care, there's no doubt that we are going through this right now. The coronavirus was obviously the trigger. The need to innovate was due to the virus. And then what we saw is there are a lot of inflated expectations. I was talking to different people who felt like, oh, okay, you know what, from now on, all of my care is going to be 70% virtual, which is it's just not realistic. When in-person care started to ramp up, we saw that most patients I could say, were said that they'd rather be seen in person. And so there's patient barriers, there's provider barriers that providers that want the status quo, organizational barriers, especially in times of these economic times, and then also return of some regulations. So this makes virtual care harder and harder. We go into this trough of disillusionment. But on the research side, I think some of the peak and the trough is just going to happen because of the public health emergency. But what we can really focus on is the slope of enlightenment. And so the idea is how should virtual care be used in practice, and how should virtual care be a part of standard medical care? And I think that researchers and policymakers can focus on this area. And probably right now, I think the top three most important issues is understanding disparities in access to telehealth, populations that are left behind, the impact of telehealth on healthcare spending, which is going to be, which is also a very important discussion piece in terms of policymaking for telehealth, and then also the connection between health outcomes and telehealth, which has been clear for hundreds and hundreds of pilot studies and randomized control trials. But the question is, how does that play out at a population level? And so this is the strike zone of health services researchers, and really been the focus of the work that we've been doing and other researchers at IHPI have been focused on. So there's no doubt that telehealth can improve care. So I'm going to have the conversation about disparities now. So there's no doubt that telehealth can improve care for populations that face challenges seeking care. So telehealth was started because of the lack of specialist care in rural areas. It removes that distance. It allows for better compliance. So a lot of reasons why telehealth could be beneficial. It's beneficial for patients who, low-income patients, for example, who can't take time off work. It's not easy to take time off work. They don't do remote work. And so for those patients, it can be, telehealth can be great, can be beneficial. And then also patients that have either financial or logistical challenges with transportation. For those patients, telehealth can be important too. So a lot of opportunities for telehealth to improve care. But the critical thing is that if telehealth is going to improve care, if it's going to reduce disparities, it needs to be accessible to these populations. And I think that's really the important part of this, is that at a population level, if it's not accessible, it's definitely not going to do anything to improve disparities in care. And so, I think when we talk about populations that may be left out, I hate when people say things like, well, older patients are not going to be able to do this. And I say that's not true. I have a lot of older patients that do this and actually show up much more than the younger patients. So it's not really about a specific demographic. It's more about essential factors that are needed for a successful telehealth visit. And so some of these demographics that we think about may have one or even more of these factors that make it difficult for them to access care. And so these factors include access to high-speed internet, so broadband internet, and access to a computer or smartphone that's Wi-Fi attached. So these two things in the literature together are called digital access. And so both of these things are necessary in order to do a telehealth visit. It's very necessary. In my practice, I thought that telehealth is great for patients in the UP, and I find out that it actually is. It's horrible. If I'm having a discussion in its current state, I should say, and if I'm having a discussion, new diagnosis of prostate cancer with a patient, and as I'm talking, because the internet speed over there is slow and my lips are moving faster than the audio, it's very distracting, especially when you're talking about sensitive issues like that. Trust and comfort. You have to have trust that your interaction is not being hacked, that your healthcare provider is doing what's in your best interest and not just trying to do a quick telehealth visit to make money. Language concordance is really important. It becomes more challenging to bring in interpreters. Technological literacy, you have to be familiar with the technology, and then also easy access to additional healthcare services. Patients in urology, for example, who have urostomies for bladder cancer, it's not the 5-minute interaction that they have with the healthcare provider with their doctor that's important. It's really the 45 minutes after the appointment that they spend with the nurses that are important for them. So there are populations that are at risk for lacking one or more of these factors. So older adults, in terms of comfort with technology, we'll go over some data on that. Rural, low income, racial, ethnic minorities, in terms of comfort with the healthcare system, disabilities, complex medical conditions that need additional healthcare services, non-English speaking. And so certain demographics can lack one or more of these things, and really these are the areas that you can target to improve and to reduce some of these disparities. So this is a study. This is the only study during this entire talk. I think I'm going to go through about 20 studies that is not from IHPI, but I like this study. It's from the Harvard group and was published in JAMA Internal Medicine. And so the idea here was that the group there were looking at digital access and essentially looked at various demographic groups and looked at the variation in digital access. So if you're at the 100% federal poverty line, about 50% of those patients don't have digital access. Again, that's either a computer or smartphone and also high-speed internet. You need both. There's disparities among racial minorities, and then 50% of patients that are over the age of 85 don't have either of these. So it's really a non-starter for some populations, or at least some segments of the population that don't have digital access. So Ziwei, one of our analysts that looked at how did this play out in the last couple of months. So we were looking at Blue Cross Blue Shield data to see certain populations that we could extract from the data. We couldn't look at racial, ethnic minorities. We couldn't look at language. There was a lot of things that we couldn't look at, but at least the variables that we could look at, we wanted to see what were the disparities like in these populations. And what we found is that there was telehealth growth in every population, at least the ones that we studied. There was no clear population that was completely left out, but there's obviously some disparities in growth. So patients that are over the age of 60 versus patients that are under the age of 60, lower use, rural, lower use, and then patients that were below median income, lower use too. So overall, from the studies that we've done, growth in all populations, but then there's a delta between vulnerable populations and their counterparts. Denise Anthony, who has been doing a lot of work for many years looking at disparities in care and looking at privacy issues that patients have. This is a study that she produced recently that came out looking at racial minorities. And we know that racial minorities are at risk for the digital divide with telehealth expansion. And this is an extraordinarily important area that we need to learn more about. There's been a lot of work in EMRs and in portals and other forms of technology. But now that with the growth of telehealth, this is actually a very, very important area for us to study. Some studies, and I'll say it's not quite clear. I mean, some studies show that racial ethnic minorities use less telehealth, but when you adjust for structural issues, infrastructure issues, other systemic barriers that they face, then it seems like there is a higher use of telehealth, or when it's made accessible, they'll use it. And so, but it has to be made accessible. This is a very interesting study in Health Affairs by Denise Anthony that non-whites were less likely to report even being offered a patient portal. So that kind of those types of systemic issues are going to be important for us to identify and be able to mitigate if we want to help reduce disparities in this population. She recently did a secondary data analysis using Pew Center research survey, and found that at least during COVID, populations like African-American, Latino populations actually used a higher rate of telehealth during this time period. And I think a lot of that has to do with that those were the communities that were most affected by the virus. But it does go to show that if access is made and access is given, then some of this disparity could be mitigated. Denise has a whole entire body of work in this, and this is just highlighting a little bit of what she does. So Lori did lead, and everyone's familiar with the National Poll on Healthy Aging, and she did lead some questions this round on concerns that older populations, so shifting from minorities to just older adults who are at risk for digital divide. And so this is a report that recently came out, very, very interesting, looking at the concerns that older adults have about telehealth visits. And 2 out of 3 of them, aged 50 to age 80, said that they felt that the care was not the same as in-person visits. That's an interesting statistic. And so the question is it is it not the same enough that you wouldn't want to do it for the other additional benefits, or is it just, in a poor quality care? So I think there's more to understand here. 45% not feeling personally connected with the healthcare provider, and I don't think that it's wise to sort of take this data and say that so this population it's not good for. It's not about that. It's taking data like this and figuring out what could we do to maximize the experience for older adults, because they clearly don't think that it's the same. And so Lori has been working in this area, and this article is available online if you're interested. Julia, I want to highlight the work that Julia's been doing. She does a lot. She leads. She's the director of telehealth for the entire internal medicine department, which is a huge population of video consultations and faculty, obviously. And so one of the important areas that she's been looking into is the use of phone with video versus video. And this is extraordinarily important because the Medicare program right now, that they in the most recent Medicare proposed rule, they actually are soliciting comments on whether or not they should even continue covering audio visits. And so they never covered audio visits before. So these are telephone calls. Then they started to cover it at the same rate as office visits during the public health emergency because of a lot of pushback from the AMA and other organizations. And now they're looking to recalibrate, should we use it? Should we not use it? If we do cover them, in what capacity do we cover them? And so this is a great study by Julia, where she used our own health system data and stratified at 5-year age marks to look at telephone use versus video use. And you can see that it's kind of like almost a perfect line where as patients were getting older, they had a stronger preference or capability of using phone versus video. And so this is really important, because if that particular coverage is taken away, then you could see a significant impact on older adults. So she's gotten a lot of attention for this particular piece of data, and we'll be putting it together in a comment letter to CMS on their proposed rule. So the main takeaways on telehealth and disparities: while there are differences in levels of adoption, there's really no single population that's completely excluded, but there's certainly populations that are at risk for having one or more factors that could lead to being excluded from video visits. So the goal should be to develop and implement policies that mitigate disparities in use. And so being flexible with technology, audio only, for example, should be reimbursed. Funding community centers for education, technical support, expanding broadband, obviously, and then also, even creating subsidies for connected devices, because for those populations where they have no digital access, again, it's a big portion that could be left out as telehealth grows. Specifically for future direction for IHPI researchers, I really think that at this point, it's time to kind of disentangle the disparities to identify specific policy targets. For example, in rural patients, it's easy to say they don't have broadband, but the truth is that a lot of rural zip codes also have older adults and also have income limitations too. So when you have the interaction of those multiple factors, then it needs to be more than just laying out some broadband in those areas. There's some work that IHPI members are work in progress right now that I'll highlight. There's a team, including myself and Mike Thompson, Jeffrey McCulloch, and Changhua and Julie Bynum and Diana Lakowski, that are looking at trying to find those highest priority barriers at a zip code level to help inform local policymakers. And then I'll highlight Shalita and Denise's work, and Grace and Julie are involved in digging deeper with qualitative research to really understand what those barriers are and policy targets to mitigate disparities. Okay, so I'm going to switch gears now and talk a little bit about healthcare spending, because that's a very important area for telehealth as well. And so anyone that works in healthcare costs knows that you first begin with understanding the perspective on cost. So are you talking about the patient? Are you talking about the providers, the health systems, the doctors, or are you talking about the payers, society costs? And so at each one of these levels, there's a different impact on what could happen with healthcare spending. And so there's an idea where healthcare spending can go up in each one of these areas. Also, a possibility that healthcare spending can go down in each one of these areas. So we can take each one of these levels separately, and I can talk about some of the work that IHPI members are engaged in here. So from the patient perspective, there's likelihood that costs will decrease. And so a lot of studies that have been done that here and other places that have looked at reduced transportation costs, parking fees, and other costs that are associated, opportunity costs that are associated with the visit. So there's certainly a decrease in cost. But there's also a possibility that costs could increase, and this could come from increased appointments. And so if provider behavior changes with the use of these lower barrier forms of healthcare delivery, then there is a possibility that individual costs for the patient can go up. Really innovative work. Shima Nasiri has been working in this area for several years, and really looking at how does provider behavior change with telemedicine. And so one of the fundamental questions here is, does telemedicine use lead to higher downstream related care compared to in-person visits? And so this graph that you see in front of you is pretty complex, but I'll try to break it down. So here we were looking at different CCS categories. So a CCS category is basically a group of related diagnoses. So for diabetes, it's all the codes that are related to diabetes is in a single CCS category. And so there's multiple bars there because there's big groups of diagnoses, and then there's little groups of diagnoses. And so her team was essentially looking at, if you compare a CCS category and you look at the in-person visits and you look at the telemedicine visits, we wanted to see whether or not the telemedicine visits had a higher frequency or lower frequency than the control group. And interestingly, when we looked across 30 days to see if there's a more related visits during that time period, during the 30 days, whether it's the initial visit was triggered by telemedicine versus in-person care, what we found is that almost across all specialties and all CCS categories, there was higher frequency of follow-up for telemedicine visits. And so there was some limitations to this study. This was older data. We were doing this a couple of years ago, and we used 2017 data to look at this. And that was a different time. And a lot has changed with telemedicine. So Shima's still working in this area to try to unpack this story. And most recently, this is some preliminary work from her group. She realized that there's one problem. And so one of the other things that we're trying to do is identify methodological ways to better look at questions in the telemedicine area. And so one of the problems that confounds this research is really the phenotype of telemedicine providers. So who's a telemedicine provider, who's not a telemedicine provider? I won't go into all the details here, but essentially there's different groups. There's adopters who went from not using telemedicine, went to using telemedicine. There are people and there's providers that are established users that have always been using telemedicine. And then there's folks that are in the middle that really have inconsistent. You can't really tell whether they're primarily telemedicine or not telemedicine. So to understand physician behavior, you kind of have to have a good strong group and avoid getting too noisy here. So when you remove these inconsistent and incomplete adopters, there's some new preliminary research that she's coming out with, is that there is a bit of a learning curve. So as providers use more and more telemedicine, actually the frequency of their follow-ups slows down and kind of returns, regresses to the mean and goes to what you would expect for in-person care. So still a lot to learn here in this area. Juan, one of our urology residents here, did an interesting study where he looked at just using our clinical data, electronic medical records, just to see, similar to Shima's study, but just on a more granular level for a single specialty, whether or not telemedicine visits compared to a control group of similar in-person visits led to more revisits within 30 days. So did you see another urology provider within 30 days of that visit? And what he essentially found was that there was no difference between the two groups. The groups that had, there was actually higher follow-up for in-person visits compared to telemedicine visits, but that was largely due to visits that were already scheduled. So it was a second opinion with a different type of urology provider. So for all intents and purposes, this study essentially showed that there was it was a substitution rather than an expansion of healthcare services. So no strong evidence of more appointments on the patient side, but there is strong evidence that patients have reduced costs per visit. So on the provider side, this can get complex. So for providers, it's possible that it's more expensive because the technology is expensive. There's subscription fees. Then there's also a possibility that these visits are more efficient. So on a per unit basis, they may reduce costs. And so that's an important policy question, probably one of the most important policy questions right now, because CMS is deciding how much to pay for this. Should we pay less per visit or less per video visit? Even if a 15-minute video visit should be paid less than a 15-minute in-person visit, or should they be paid equally? And so they're soliciting comments in that area too. So David Portney, who's one of the all-star medical students here, worked a couple summers ago on this project where he wanted to understand that precise question and understand whether or not it costs more to do a video visit or an in-person visit. And so he was in clinic with a stopwatch, essentially timing how long each visit took, figured out who's coming in and out of the room, and applied this pretty sophisticated methodology called time-driven activity-based costing to come up with the per unit, per minute, per hour cost of each healthcare encounter for the patient from check-in to check-out. And so what we essentially found with this study is that the healthcare spending was about the same. The labor cost of the healthcare provider really dominated the expense of the visit. And so what we also found interestingly and not really expecting was that people were actually spending more time on virtual visits than they were doing in-person visits. And so, this is limited to a single clinic in urology and general surgery, but it's really interesting to think about because reducing payments may actually create a pretty strong disincentive for providers to use virtual care with patients. So finally, probably the most interesting for health systems, for insurance companies is the effect on the payer. What's the healthcare spending going to happen, or what's going to happen to healthcare spending? And so costs can increase if there's more appointments, there's new billable services. But the big idea here is that healthcare spending can go down if you're avoiding emergency room visits and other expensive events. And so this is, Kathy is also an all-star. She's one of the research fellows in emergency medicine and has been doing excellent work with studying telemedicine for a while now. And so her research question, one of her many research questions was to understand how does the use of telemedicine prevent emergency room and urgent care visits, i.e. does it reduce payer costs? And because those are expensive encounters and visits. And this is actually the fundamental belief that that Blue Cross Blue Shield had when they started to cover video visits, is because they were told by industry and companies that do telemedicine that patients are going to use this instead of going to the emergency room. So it's a pretty simple model here. You have symptoms of an upper respiratory infection. Telemedicine visits are cheap. Urgent care is expensive. So you're going to choose urgent care instead of the emergency room. And that's a model that it could be possible, and it is sort of like a perfect substitute model. But what Kathy wanted to understand about this is really, well, is it a perfect substitute? Is it just another access point, which actually leads to more healthcare encounters downstream? Does it lead to more urgent care visits and actually leads to more primary care visits or even secondary telemedicine visits? And so she used Blue Cross claims in the state of Michigan. We were specifically focusing on a specific condition, which is symptoms of upper respiratory infection, and then also looking specifically at a single payer and also a single form of telemedicine, which is called direct to consumer. So it's not the telemedicine you get from your primary care doctor. It's actually telemedicine with a national telemedicine platform like American Well, Teladoc, those companies. And so what happened to downstream visits? And this is under review right now. And so essentially what we found is that there was a small increase in additional healthcare encounters when the visits were initially initiated by telemedicine versus a control group of visits for the same condition where patients went to their primary care doctor. They essentially were seen more commonly in the office within 7 days for the exact same condition. They were seen about the same amount of time in the emergency room. Urgent care was slightly higher, and additional telemedicine visits were slightly higher too. So it's hard to know where this lands. What we see is that it's not egregious. We don't see huge increases in urgent care visits and emergency room visits. It's just a small increase, it's possible that even all of these telemedicine encounters may have started at the urgent care room if telemedicine wasn't available. So without knowing that entire population, it's hard to put that put this study in that context, but it does show that at least that these visits are not so suboptimal that that a huge portion of these visits require downstream care within 7 days for the same condition. So the main takeaways in future work in telehealth and cost, telehealth that can impact all three different levels. Patient side is probably going to save costs, but you do have to monitor for overuse. On the provider side, it's likely going to be either cost neutral or actually more expensive. And then at the payer side, we don't know. And really, the final answer on this is going to depend on whether or not telehealth is a substitute for traditional healthcare or if it's an expansion of traditional healthcare. And so I think the future work in this area with IHPI researchers should really focus on understanding this substitution versus expansion model. So finally, I'll talk about healthcare outcomes. And so when we're thinking about healthcare outcomes, again, with telehealth, this is not a new thing. It's been around for a long time. People like John Pate and Lori have been working in this area for a very long time, decades. And so the idea here is that when there have been studies that have looked at can you improve care using telehealth, and a lot of randomized controlled trials and pilot studies are favorable. But one thing that's really important is that it's not so much when this is applied at a population level, your outcomes may be different. And so it's not so much the technology or the device or the app that improves healthcare. It's actually what's the underlying mechanism of that particular technology. So is it providing easier access to a healthcare provider? Is it improving the frequency of patient and healthcare provider interactions, like in remote monitoring, for example, or is it enabling self-care? And so these are some mechanisms. There's more mechanisms, but I think that's important to understand when you think about how the technology can improve outcomes. So when you think about video visits, there's really the strongest mechanism here is easier access to a healthcare provider. There have been few studies that have actually looked at video visits and whether or not there's improvement in clinical outcomes. And usually those studies are looking at making sure it's not inferior to in-person care. And so you could say that, well, so we don't have data that shows that video visits improve care, but we do have a lot of data from IHPI members like Sarah Reeves and Allison Lin that have looked at access to specialist care for particular conditions. And so access to specialist care can improve health. So this is a systematic review that Allison completed, and Allison's an addiction psychiatrist here. And so one of the fundamental problems is about 56% of rural counties lack a physician who can prescribe medications to treat opioid use disorder. And so telehealth is an area where telehealth can improve this by improving the bucket of providers that are available to provide this kind of care in rural areas. In her systematic review, she found that most studies suggested that telemedicine was associated with higher satisfaction, and was effective when other treatment was limited. But of course, there's going to be more rigorous study that's needed for this area to see is there a direct connection between the use and outcomes. In remote monitoring, it's about increased frequency of interactions. That's really the playbook of how remote monitoring can improve care. There have been a lot of studies in this area, COPD, CHF, a lot of chronic conditions, Lori with hypertension, that have shown that it can improve care. One of the big questions still out there is that how is it going to work when it's at a population level, when it's implemented at a health system. The Telehealth Research Incubator did help secure some funding for the Michigan Medicine through the FCC to build a home monitoring program. And so that's led by Grace Jenkins. She has been doing a great job with this and really looking at how this can actually improve outcomes for patients. One example is that there was a young male history of diabetes who had multiple readmissions during January through March. He was enrolled in this program and really had no readmissions since the last time I checked with Grace. But the patient results are very highly variable. I've talked to Grace quite a bit, and really depends on the clinical tools available. So it's not so much the technology, it's what you do with the technology. Do you have the specialists that are giving you input? If you have an issue where a patient needs to be treated at home, do you have the community paramedics there? Do you have the home therapy? So I think with these types of monitoring programs, the answer is not going to be very straightforward until you see the whole ecosystem of things that go into play to keep patients at home and avoid hospitalizations. So it's not the technology, it's how the technology is used. Clinical outcomes that are observed in randomized controlled trials will likely be different when observed in practice. And then one particular study I'll highlight is Sarah Reeves submitting an R01 to understand how telehealth improves access and outcomes for patients with pediatric sickle cell disease, which is a rare condition. And so that improved access could lead to improved care and improved clinical outcomes. So I could keep talking, but I know that my time's limited. So I just want to say thank you to all the IHPI investigators that are really telling the telehealth story. It's been great working with a lot of people and also being able to take other people's work, collaborate with them, and then also try to disseminate this story. And so if you're interested in telehealth, I think you could certainly add to the story, join the Telehealth Research Network. You can email Emma to get added to that. We send out opportunities. Most recently, we sent out we're writing a collective letter, so putting our research together to write a collective letter to CMS for the proposed rule. You can also just send us completed work if you are working by yourself, but you just want your work disseminated. We could help integrate it and tell the telehealth story and disseminate that information. Just recently, in the last couple of months, I've been giving a lot of talks to Department of Health and Human Services, Physician Technical Advisory Board, the health plans, Michigan Legislative Forum. A lot of people just looking for information, looking for health services research lens into telehealth. So send the work to us. We could help package it in a way that could get into hands of people that can make a big impact. I want to thank Erica, who soon will be putting together a data wall that would help us kind of put a lot of these studies out there and make it very accessible for journalists and for policymakers. And I think most importantly, just talk to us if you're doing telehealth research. Likely that there's probably someone else that's doing something similar or has done something similar that we can connect you with so that you're not reinventing the wheel. So I'll leave with this quote, one of my favorites from Tim Cook: technology is capable of doing great things, but it doesn't want to do great things. It doesn't want anything. That part takes all of us.
Thank you. I love the quote. Thanks so much, Chad. It's wonderful to see how far this has come. I think this is a real example of just how something has taken off. I remember one of your first presentations to IHPI about this idea, and now to see this presentation is truly fantastic. We have a couple minutes for questions. I can't imagine no one has any questions. Type them on into the chat, and Stacy can help to unmute you if you want to ask Chad a question. Okay, we have a question. Why don't we unmute Antonius so he can ask? Please.
Through this talk, I learned a lot from it. I was wondering about the effect that telehealth adoption might have had on the revenue side. You mentioned earlier that increasing the telehealth or visits overall through telehealth was critical for financial viability. So especially for rural hospitals, there was information on how they were at the brink of collapse. Has telehealth helped or telehealth adopters been better off in this market exit decision they might be facing? And is it work from prior researchers?
Yeah, so I can kind of speak to that from sort of like observing more so than the research side, but just kind of what we've seen on the operational side. And I think that telehealth really was just able to salvage care rather than really become like a good, strong business model. I think for the last, there was a lot of practices kind of held off on doing telemedicine because you just wasn't sure how long it was going to last. And they were obviously kind of financially hurt more. But I think that across the country, there may be some folks that were really able to kind of turn it around quickly. But what we see, especially at large health systems, is that they were salvaging about 20% of the care that was compared to the 2019 numbers. So if anything, it was salvaging, and a lot of it was obviously they're all E&M visits, which stopping elective surgeries and so forth were just much more financially detrimental. I think that there's what happens from like a business side for virtual care expansion is tricky. there's certain types of technologies like using remote monitoring. They're actually, the way that the payer system is set up right now is actually more expensive. So you can loan technology to patients, but if you need some sort of intervention done, like you need, and this is a conversation I've had with Grace about this in our home monitoring program, if you need a paramedic to go to the patient's house, their insurance may not cover it. So is the health system eating that cost? Like there's a lot to think about there. So from the monitoring side, that's a primary issue. From the video visit side, there's kind of pros and cons, or there's potential increases in revenue, potential decreases in revenue. I mean, what we see is that there's a lot of billing levels that are kind of sliding because of virtual care. People bill at lower levels. That's going to have a financial impact. But I don't see a lot of evidence of just kind of overuse and a lot of financial gain from you using these. And part of this is in the context of a public health emergency. So it's unclear 12 months from now, when people are kind of, really building it and thinking about the business model, whether that's going to change.
Great. Well, we are at time. Normally we would be having a reception with you afterwards. We could mill around and ask questions. But we are at the end of our time today. So thank you so much, Chad. If you want to stay on for a minute, if anybody has any, final
Sure.
questions. But thank you all for joining. I think this was really a fantastic kickoff of our series, and look forward to seeing folks coming back for our next ones. Thanks again, Chad.
Thanks.
I do have a question for you.
Yeah.
I was just really struck by, and we run into this too in the, on the research side of things sometimes with your comments about the promise of telehealth, but then the limitations of populations with technology and smartphones and the digital access. I mean, do you see any, has there been any kind of discussions about a role for like insurance or other entities to kind of help meet that? I live in a rural area too, and we kind of struggle with that too, just the bandwidth issue, like providing patients with iPads or things to enable virtual visits. Has any of those conversations come up at all?
I've definitely heard those conversations, but it's mostly, at least the conversations that I'm available to listen to. I think that it's kind of been they're mostly like ideas rather than,
Yeah.
I'm not aware really, at least at our system level, if there's such a plan, or of the payers that I know of that have been actually like giving devices, because it kind of makes sense. Like that is,
At some point, yeah, maybe cost effective if that.
It will, exactly, yeah, and that may be a model in the future. I think that if you, like from a payer standpoint, it kind of makes a lot of sense if you can identify like the highest risk patients and then give them the ability to enroll in a monitoring program. It will be a savings for you. So
Yeah.
But especially since the technology is so cheap.
It's getting, yeah, exactly.
Yeah. Relatively, I guess.
Yeah. All right. Well,
great.
We really appreciate you, Chad, and thanks so much.
Yep.
We'll be reconvening on the 8th for our next presentation by Dr. Preeti Milani. So thanks everyone who's still on, and please come back on the 8th, join our next seminar. Take care. Thank you, Stacy. Thank you, Jason.